maybe this point may be slightly ironic to you given the previous discussion, but there have been implementation principles agreed, across all 4 UK countries, and the purpose of the principles is to make sure that this is consistent and transparent, and that it's proportionate, and that when a doctor's revalidated in one part of the system, that's on the reasonably consistent basis compared to another. These are the kind of broad principles that the 4 UK governments and the GMC have agreed around this, and clearly, without reading them out to you, it's clearly about putting patient safety at the heart of it, and that may not be immediately directly relevant to the context of some people, but clearly it's important that that's driving this process. That the responsible officers they know best about their particular context, and therefore they should be in the driving seat in terms of how this pans out, in terms of the pace and so on of the process. That this can't all be done overnight, that there is, inevitably, as I said, 0 to 230,000 isn't going to happen overnight. And we've said that probably will take up to 5 years for that number of doctors to have had their revalidation recommendation made. But we and the 4 governments have agreed that we'd like the vast majority, to have had a revalidation recommendation made within the next 3 years, well, 3 years after commencement. So there are principles sitting behind this process that everyone has signed up to, and I think that's worth bearing in mind as we go along. Okay, so those are the principles. In terms of the recommendation process, just to clarify this, when it comes to a responsible officer making a recommendation to the General Medical Council about the licence of a doctor, there are basically 3 pathways, or 3 options that the responsible officer can bring. The vast majority, we anticipate, will be, this doctor has been doing what they need to do, they've been in an appraisal, I have no concerns, I recommend that they be revalidated. And the top box there represents that. There may be circumstances in which a responsible officer feels they need more time, or the doctor needs more time, whether it's to gather more information or whatever it might be, and that at the point when the revalidation submission falls due, that more time is needed. And so there will be a mechanism for requesting more time, which we refer to as a deferral. And there will be, that's still relatively small numbers, but there will be legitimate and reasons why that is necessary, and therefore we need to have a mechanism for that. But given that this is a statutory process, and when the revalidation regulations come in, we anticipate at the end of this year, they bring with them duties on individual doctors to participate in this process. There then needs to be a mechanism for the GMC to be made aware if there is a doctor who's simply not engaging, not participating, and not doing what they need to do, in the opinion of the RO. And so there will be a mechanism for the responsible officers to notify the GMC that that's the case. The doctor's not been turning up at appraisals, not been gathering information, not been doing anything towards it. I simply won't be in a position to make a recommendation about this individual. Therefore, I'm notifying you, GMC, and it's over to you to begin to engage directly with that doctor. And of course, under the regulations, the end point of that process, if a doctor isn't engaging and continues to refuse to do so, the end point of that could be that their licence may be taken away from them by the GMC at the end of a legal process. Again, the box at the bottom emphasises that there is not a new way to raise concerns about the practice of doctors. If there's a concern about the fitness to practice, that needs to be flagged up as soon as it emerges, not as part of this 5-year cycle. That has to happen whenever it crops up. Currently, we're developing and building all these systems. We're giving responsible officers access to the IT system that will drive all this as we speak. So that this will all be done. This process, these mechanisms, will happen through an electronic mechanism, through a web-based IT system. In terms of supporting responsible officers to do what they need to do, we will be publishing in the next couple of weeks a detailed guidance for responsible officers in the conduct of this process, the conduct of their statutory relationship with the GMC, the mechanisms for making recommendations, the criteria and circumstances in which they make one recommendation versus another. So again, that guidance will be out there in the next couple of weeks, months and months in advance of anyone actually having to do this for real. So there's a long pickup period for people to become familiar with what's needed, a long opportunity to engage in any clarifications or so that might be needed as part of that. As part of the responsible officer protocol are the formal statements that the responsible officer, if you like, signs up to when they make these recommendations. And if those of you who have seen the IT system, when you go to make a submission, it comes up literally with the statement on the screen saying, you know, I'm signing up to this statement. And that underpins the fact that there is a statutory basis to this, and when you do make a recommendation, you are making a statutory statement, if you like. But to help, also help and support the process, we'll be developing case studies and scenarios for people to look at, to illustrate the if you like, which pathway that responsible officers would go down. The vast majority, we would expect, would be making positive recommendations about the vast majority of doctors. This slide just summarises what the various responsibilities are within this. Of course, employers who are designated under the regulations have to appoint a responsible officer and put in place the systems and processes and resources to support them. Responsible officer then is, of course, responsible for overseeing that process, for being aware of all the doctors they've got in their portfolio, if that's the right word, and to provide or support doctors in getting access to the supporting information they need. And of course, the regulations, the revalidation regulations, when they come in, as I said, bring duties on doctors individually to participate in all of this process. So it's not, if you want to put it that way, it's not discretionary on the part of anybody. This thing is operating within a statutory environment. Just in terms of bringing you up to date with where the GMC is in linking in with all the doctors that we need to link in. Clearly, 230,000 doctors. We need to be able to link each doctor to a designated body or to a responsible officer, or both. We've got information about people working in the NHS through electronic staff records, so we've been able to pre-populate those connections for those doctors. We have or will know the connection of doctors in training, because their prescribed connection is to the deanery within which they're operating. So already, you know, that's 180-odd thousand doctors where the connection has already been established. We're currently gathering further information about those doctors where there was no, if you like, known previous information about their connection. Roughly half of those are practicing outside the UK. And of the others, we're currently working through a process to link in with those doctors, to writing to them, asking them to log into GMC Connect, GMC Online rather, and to inform the GMC what they believe their prescribed connection is. There will be a series of letters and reminders going out to people where they've not been able to do that.
Sorry to ask you yes or no question. Can you just clarify what would you mean by prescribed connection designated body? Well, this is for independent doctors.
Okay.
Which is relevant to our occupational position.
The concept of prescribed connection and designated body arises from the responsible officer regulations. Right. It applies irrespective of the context in which you're working. In other words, if you're in the private sector or not in the NHS, this is not a public sector concept, put it that way. It's a statutory concept that applies, you know,
so it's a
generically.
Body that takes responsibility for the doctors that are attached to.
So under the regulations, the concept of a designated body is set out. So it sets out the criteria for what a designated body is. Essentially, if you're employing doctors or working with doctors, then you're likely to be designated as an organisation. If you are designated under the regulations, then you need to appoint a responsible officer.
Right. If you're an independent doctor. self-employed, like viewers here,
Yes.
then what?
Well, there are other avenues available. For example, the Independent Doctors Forum is designated as a designated body, and so I don't know what the SOM is.
Faculty of Occupational Medicine.
The Faculty of Occupational Medicine is a designated body for independent doctors, basically.
So we just contact the faculty and
Yes.
ask to sign up.
If you're members of the faculty would be, and if you're a designated body and you have a link with a particular, or the doctor has a link with you through their, either through membership or employment, that's called a prescribed connection.
Right, and so if you're a very small company, you don't have the resources to have a responsible officer, you can pass that duty, as it were, to our Faculty of Occupational Medicine. You don't have to have your own responsible officer.
If your members have a link to the faculty, then potentially that's an avenue. Right. I mean, there are other discussions happening about very small organisations currently. There's an organisation called the Independent Healthcare Advisory Service. There are some doctors, we think, who within the regulations, and there is advice available to individual doctors about this, either via the website or via the GMC's dedicated helpline, which I'll give you the details of at the end. There are a small number of doctors who may not have a prescribed connection. Or there is, we think, a minority of doctors that may not have a prescribed connection within the currently constituted regulations. So what we're doing is we're developing, if you like, an approach that allows doctors who don't have a prescribed connection under the statute to still have a connection to someone who will act as a responsible officer on their behalf.
Can I ask a question about that prescribed connection thing? We've got some contractors who do, say, 2 days a week for us, a day for somebody else, and a day in the NHS. I'm led to believe the NHS takes precedent, even though they're only working a fifth or a fourth of their time within it.
No, the NHS doesn't take precedence. Employment relationships take precedence.
So what if someone is employed by 5 different people in a week, for arguments?
Well, the regulations have a way of dealing with that, which is by looking at the balance of work between the different providers, and ultimately, if it comes down to it, it will be determined by the registered address of the practitioner.